I'm going to talk about the state of radial intervention in the U.S. I have no disclosures other than I'm a card-carrying member of the Radial Club, so I'm quite biased here, but I think for a good reason. Anyways, a quick outline here. We'll talk about the background. We'll go over some data, patient outcomes, the patient experience, and some hospital measures. We'll look at adoption of transradial intervention in the United States, some current guidelines, some of the barriers or myths, and then a brief discussion of the process to initiate a program. So background, this is real brief here. Historically, Dr. Radner was the first who attempted a transradial coronary angiogram using a cut down. In 1989, Dr. Campo, who unfortunately recently passed away, published the first series on diagnostic angiography, and Dr. Kimeny, also one of the pioneers, performed the first angioplasty with stenting through a guide catheter through a percutaneous radial approach. It's almost 25 years ago. So, you know, the background here is really a problem of bleeding. You know, this is a chart from an NCDR data of a great many patients describing bleeding rates in patients based on their presentation. So regardless of the presentation, bleeding is an important problem, both access site in the blue and non-access site bleeding in the red. But you can see with the more acute presentations, the overall rates of bleeding increase. So is it important to bleed? If you bleed, yes, it actually is very important. This is a meta-analysis pooled data of over 100,000 patients looking at major bleeding with ACS, demonstrating a marked increase in the risk of dying. This is similar data that demonstrates a significant increase in the risk of MI and stroke in addition to death, with hazard ratios of 4, 5, or 6 times more likely for these bad events to happen if you have a major bleed. What about the effect of site of bleeding? Is this risk just from non-access bleeding or access bleeding? The answer is both. Clearly non-access site bleeding is more risky, but if you have access site bleeding, there's still an increased hazard ratio with the outcomes of mortality at 1 year. And again, this is just pooled data. It's been replicated several times. Well, what about transradial versus transfemoral approach? This is pooled data of randomized trials, 7,000 patients, that show that there's a clear statistically relevant decrease in major bleeding. This is not a debatable point. There's about a 70–80% reduction in the risk of bleeding with a radial approach. So some of the rationale is that, you know, patients with acute coronary syndrome, which is primarily a thrombotic problem, they receive very strong antiplatelet and anticoagulant therapies to improve their ischemic events. Bleeding complications remain an important problem, particularly with PCI after ACS, and bleeding is associated with really bad things, death, MI, and stroke, and transradial access with PCI reduces bleeding. This is some additional advantages, of course, include patient comfort and convenience, immediate ambulation, shorter length of stay, and reduced hospital costs. So that's kind of just the thought process. What about the actual data? So I wanted to briefly run through, without doing too many of these types of slides, some of the trials here. Before I do that, I just wanted to summarize outcome definitions. We'll be using these terms MACE, major adverse cardiac events, which is death, MI, stroke, and sometimes revascularization. NACE, which is basically the MACE outcomes with bleeding, which is a net adverse clinical events. And p-values, as you know, less than 0.05 are statistically significant, meaning the intervention has a meaningful outcome on that, effect on that outcome. So the RIVAL trial was studied, something that was published in the Lancet several years ago, which was one of the first major randomized trials in non-ST patients and ST patients, about 7,000 randomized to radial or femoral access across multiple centers and countries. The primary outcome was a NACE outcome, death, MI, stroke, and non-CABG related bleeding. Now, in this trial, there was no significant difference, which can be viewed a lot of different ways. Certainly, radial wasn't demonstrated to be better, but it certainly wasn't more harmful, with similar rates of the primary endpoint, which again was a NACE outcome. When the outcomes were stratified, however, by the type of presentation, STEMI versus non-STEMI, the STEMI group demonstrated a significant reduction in the primary outcome. And looking at the components, there actually was a significant reduction in death in the group of STEMI treated with a radial approach versus a femoral approach. Now, it wasn't designed specifically for this, so this was somewhat hypothesis generating, but it was still very interesting and meaningful, on nearly 2% reduction in that group. That led to some additional studies looking prospectively at this question. The STEMI Radial trial, which looked at 700 patients in Czechoslovakia, also randomized a femoral or radial approach. The primary endpoint defined there was softer, just bleeding and access site complications, but significantly reduced with the radial approach in the gold versus a femoral approach, about a 6% reduction in these important bleeding and access site complications. When looking at the MACE in this trial, there wasn't a significant difference, although the numbers were smaller, and there was kind of a numerically favorable effect on multiple outcomes here, particularly death as well, but not statistically significant. Another trial looking at the same question, the Rifle trial, looked at 1,000 STEMI patients. This was in Italy, very experienced center, very sick STEMI patients. They included pretty much everybody. They randomized again to femoral or radial intervention for their STEMI. Their primary endpoints were NACE, as well as bleeding individually, both of which were markedly reduced with the transradial approach. Actually, the MACE independently was reduced, and the components of the MACE, interestingly, was driven by a reduction in cardiac death. The other outcomes being somewhat similar, but cardiac death was reduced by 4% in the radial group. Now, that's an extremely significant absolute reduction, so much so that many people didn't believe it, but it was in line with the direction of the benefit of the previous trials. As far as bleeding, as you can see here, it was all access site bleeding, as you might expect. That was reduced by the radial access versus the femoral access. That led to probably the most potent study looking at this question, the Matrix Access study, which was published last year in The Lancet. About 8,000 patients, again, this time non-ST, NST, similar to Rival, transradial or transfemoral. It's a very complex randomization that looked at access as well as some other antithrombotic regimens, which we won't talk about. But in the access component, one of the endpoints was a MACE endpoint, which showed a 1.5% reduction. Now, they had defined significant as 0.025 in this study, so it technically didn't meet it at 0.03. But had they used the traditional definition, it would have been significant. When they looked at the NACE outcome, it was, even with that more stringent definition of significance, an important trial that showed a 2% reduction, which translates to 50 people needing to be treated to prevent one of these outcomes. At the same time, the group published an updated meta-analysis or pooled analysis of all of the randomized data looking at this question, which included nearly 20,000 patients. And what they found was pretty impressive. In all of these major outcomes, non-CABG-related bleeding, again, death here, points on the left side of the line favor radial intervention, and those that don't overlap the midline show a significant decrease, about a 28% reduction in death. Importantly, they also demonstrated that stroke, as you can see right in the middle line, was not different between the two, something that had been a concern. So just to put this in context in terms of the degree of benefit, there's obviously people in the audience that have different kind of number of years in the business here, but going way back to when we used TPA and we compared it to streptokinase, that provided a 1% incremental benefit in death reduction for acute MI. We moved to primary PCI versus lytics, which provided about a 2% reduction in addition to stroke reduction. When we looked at door-to-balloon times, we knew that getting arteries open quickly, less than 60 minutes compared to more than 120 minutes, provided a 50% reduction in mortality. And putting that data of the transradial in context, there's a 2% reduction. And this is just a strategy difference. This is just doctors and nurses and techs making a decision to do something one way and learning to do it well. So what about the patient's experience? Other than not dying, they looked at other kind of patient measures as to the experience with respect to transradial and transfemoral. This is one representative small study that showed that, it's kind of hard, it doesn't really, more busy slide, I'm not sure if you can read that, but basically physical, mental, and social function were all statistically approved by this validated questionnaire with a transradial approach. Also, in the Rival trial, they had asked the patients, when randomized to radial or to femoral, which one they preferred, if they preferred the same access site, and 90% of the radial patients did, but only 50% of the femoral patients did. So what about the hospital? How does the hospital feel about it? The bean counters? Well, they love it. So this is looking at 7,000 PCIs in 5 different U.S. hospitals, length of stay by bleeding risk. This is just the summed patient total. There was a reduction in the length of stay of 0.38 days, so half a day difference, which obviously saves money, improves throughput, and so on. That translated into significant a dollar amount saved, so an average of $830 per patient per PCI. So I've shown you, I think, wonderful clinical data. I've shown you that patients like this and the hospital likes this, so this should be kind of the norm, right? Well, that's unfortunately not the case, as probably you all know. I will kind of go over now how this has been adopted in the US. Now, this is a little bit dated. This is the most recent published data from the NCDR, although there is some other data that shows that things are still rising, but this is some summary data between 2007 and 2012, 1,381 sites that reported and nearly 3 million patients. This just demonstrates a graph of the number of hospitals that do this percentage of radial. So as you can see, it's all clustered near, less than 20% radial case volume, with very few centers doing more than half the patients transradially. As far as a trend across time, from the start 2007 to 2012, there is clearly a meaningful increase, but the overall rate, this is at the end of the last quarter of 2012, there was still just 16% of overall patients getting PCI transradially. You can see here, this is the upper, the higher rate here is in patients less than 75, that grew faster. Male patients seem to grow faster than female patients in terms of rates of radial cases. Type of presentation, and this is important, the STEMI patients are the lower graph here, those that actually grew less quickly, and that was the group that may potentially have the most benefit. And by region, so there's a lot of regional variation, with the Northeast, our area here, being the most quickly to uptake this strategy. So all those things kind of demonstrate what we find called the risk treatment paradox, where people most likely to benefit are least likely to get it. This is just a summary of that. 17,000 patients. The columns here are low bleeding risk, intermediate, and high bleeding risks as predicted by their variables. Black is femoral, light is radial, and you can see with higher predicted bleeding risk, femoral use increased. So it was actually being applied kind of incorrectly. So some of this may be related to our guidelines, and we'll see what our guidelines say. The most recent, these haven't been updated recently, 2011 guidelines by the ACC for PCI suggests that radial access is a 2A indication, which is positive, but it's not the strongest recommendation, and it's pretty soft language that it can be useful to decrease access site complications. As far as the recommendations in the setting of STEMI, there's no formal recommendation. It just says should be considered when feasible, which again is quite soft. Compared to European guidelines, which were just recently updated in response to the MATRIX trial, they've given transradial PCI for acute coronary syndrome a class 1 indication with level of evidence A, which is literally the strongest recommendation that can be given. Their STEMI recommendations haven't yet been updated, but they will be. It currently are a 2A recommendation, and it really is said to be preferred method of access for all angioplasty. So what are the barriers to this? Well, there's a lot of barriers. I mean, I think that this is a summary of some of them. There's a lot of myths, but one big one is a fear of procedural failure, concerns over some complications with this procedure, namely that the radial artery can get chronically occluded, and different issues with radiation and procedural time expectations. So what about fear of procedural failure? This is a summary data from that NCDR trial of nearly evaluation of nearly 3 million patients. And these are adjusted values to the patient's comorbidities. There was no difference in the procedural success between radial and femoral PCI, but there was a reduction in vascular complications and bleeding complications, as we've seen in prior studies. Another group, this is a complicated flow, they looked at trying to predict transradial PCI failure, and they found that they could create a score that was relatively simple. Female sex, prior CABG, and cardiogenic shock were predictors of failed transradial access, and using a combination of these variables create a score that could predict the likelihood of failure. So, a woman who had had prior bypass and presented in shock had a nearly 80% of failings, which basically meant that you could go femoral in that patient. And that's really the gist here, that it's a radial first strategy, not radial only, but the prevalence should be much higher, particularly for patients that are eligible. As for sheath size, radial artery occlusion and the risk of that, it's silent, as you can see, as an occluded radial artery, because there's a lot of palmar collaterals and the hand is not jeopardized when this artery is occluded. We've learned a lot about this, so this risk is actually more a little bit more antiquated. It's real, but the risks are much less than previously thought. With full anticoagulation, there's a meaningful decrease. This is no heparin, medium, and full dose heparin. So patients that get even diagnostic angiogram should get full dose heparin, and they have reduced risk of radial artery occlusion. Patent hemostasis, the manner in which we take out the sheath, is very important. I'll go over that in a second, but there's a significant reduction in radial artery occlusion when patent hemostasis is used. What is patent hemostasis? It's exactly what it sounds like. It's hemostasis while the radial artery is still patent. How do we know that? Well, we apply a band called the TR band, and there's other versions of this, which applies pressure to the radial artery such that there's hemostasis, which we visualize. Then we occlude the ulnar artery while the thumb is measuring the pulse ox waveform. If the ulnar is occluded and the waveform remains, that means the radial artery has to be open, and we've defined patency. So if there's no hemostasis and this waveform remains while the ulnar is occluded, we have patent hemostasis, and the risk of radial artery occlusion is nearly zero. This is called the reverse Barbeau test. Sheath size, we know that smaller sheaths result in less radial artery damage, injury, and occlusion. And there's equipment that's better than even just 5 years ago. This is a sheath from Terumo where the inner diameter is that of a 6 French system, but the outer diameter is that of a 5 French simply by making the wall thinner. Radiation and procedural time. Radiation exposure by the operator is higher with radial procedures, but as you can see, low volume operators with femoral procedures are low volume radiation operators. So it's more issues of radiation hygiene. As far as what are the effects of experience on that, if you look to the right here, this is radial operator volume. Low operators did have higher radiation exposure by air coma, but as the experience level went higher, that difference narrowed. It was not different. So how to initiate a TR program? Really, hopefully a lot of you are already in these places, but if not, I'd hope for you to advocate for these things. It really starts with patient selection. And this was guidelines for that, starting with easy diagnostics, easy angioplasties, all diagnostics, all angioplasties in acute patients. Getting comfortable with the equipment, once you do it several times, you become very facile with it, and it doesn't become second nature. Left radials can cross over, and there's a board here that can make right radial interventions easier. Understanding that there's a learning curve. After about 50 cases, there's a large decrease in the amount of time it takes to do a procedure, which then flattens out. So just tolerating and getting through that is very important. Understanding the post-procedural care and managements, the reverse Barbeau test, like we mentioned. And finally, understanding that everybody needs to advocate for this and advocate for their patients. This really is a better way of doing things. A lot of patients are asking for it, and just knowing that it is a team effort. So that's it. Thanks a lot for your attention.